So, role pediatric registrar working in busy district general hospital, setting children's outpatient department. You're talking to Mrs. Harris, mother of 11-month-old Oliver. Oliver has been attending your clinic over the last 4 months, undergoing investigations for neurofibromatosis type 1. His father also has the condition. Oliver has been seen this morning by tertiary genetic team who has confirmed the diagnosis. His mother has asked if you could explain the diagnosis again to her, as although her husband has the condition, she has never really understood what it means. Okay, so please explain the diagnosis of neurofibromatosis type 1 to Mrs. Harris. Points to consider. First, establish her background level of knowledge, as this will be your starting point. So this is previous knowledge. Explain that neurofibromatosis type 1 is the most common of the neurocutaneous syndrome. You will need to explain what do you mean by the term neurocutaneous. Then try to go through the condition in a structured format. The first is the genetics and inheritance. Clinical diagnosis. Here you should know that the diagnosis is made fulfilling 2 or more of the 6 main criteria and be able to list this criteria. Associated clinical findings and complications, management and treatment, follow-up and prognosis. Confirm Mrs. Harris' understanding and answer any questions that she may have. There is an excellent website on neurofibromatosis, which you could direct her for further information. Okay, this is the website www.nfauk.org. Okay, provide written information and arrange follow-up. The diagnostic criteria and associated complications are available in standard pediatric textbooks. So the change in the scenario here now is, okay, okay, same. Oliver and mother is Mrs. Harris, okay, and he is, okay, you can keep 11 months or 1 year old, no problem. 1 year old. He came for the outpatient department as he came for examination for some other condition like URTI or something. Okay, but accidentally some features of neurofibromatosis were seen, like cafe-au-lait spots, some axillary freckling like this. Okay, you're hearing me?
Yes.
And by the because this is a clinical diagnosis, and if the criteria is 2 or more, it will be diagnosed, right?
Yes. So the father has the condition or not? Then
no. Here it is like breaking bad news. We are changing the scenario to breaking bad news. Accidentally, you find out that there are features which are going with, see, 2 or more of 6 main criteria. Accidentally, the evaluation, the child was admitted for some other purpose, like normal infection, maybe some pneumonia or something like this, which is not related to neurofibromatosis. But accidentally, the consultant evaluated him. And when the consultant evaluated him in the ward, he saw that there are features of 3 criterias, major criterias growing with neurofibromatosis. Okay, so he had some busy on call, so he couldn't explain. He want you to explain to her the diagnosis of neurofibromatosis. Okay, like breaking bad news. The patient, the mother doesn't know, and accidentally it was found out. Okay.
Okay, doctor.
Okay, the same names, Oliver, and he will be 1 year old, and mother is Mrs. Harris. And what are the features you saw is mainly the multiple cafe-au-lait spots. Okay, you can remember as some axillary freckling, and in 1 or 2 places neurofibromas like this. Okay.
Okay.
Okay, so I will give you 4 minutes, 3 minutes from now. Once you are ready, we will start. Okay.
Yeah.
Okay, start. You can start now.
Okay. Hello.
Hello.
I am Dr. Reepa. I am a pediatric doctor here. I believe I'm speaking to Oliver's mom, Mrs. Harris.
Yes, doctor, it's me.
Yeah. How would you like me to address you, Mrs. Harris?
I think Harris is fine.
Harris. Okay. Okay, that's nice. So, I just wanted to update you regarding Oliver's condition. Is there anyone else you would like to join us for this conversation?
No, doctor, I am alone, but Oliver is doing fine. Is there anything, doctor, you want to discuss?
Yes, you're right. He's doing fine, and he's appearing quite well now, and it's good, right? You feel
Yes,
he's
doctor.
doing good, right?
Yes. He's fine from before now.
Yes. But you know what, Harris, we do examine the kids, although he had just come for a cough and cold this time, we do check the babies extensively, and so it's about something that, is it a good time to continue?
Yes, doctor, I want to know. Actually, I thought we will go home now in few minutes. So I thought you will be telling me about it. Is anything else, doctor?
Yeah. So basically, that day you did mention about the birthmarks. You remember that?
No, doctor.
Yeah. So basically, we have seen that he has some birthmarks all over his body. And have you noticed that? Because I remember you telling me that. Have you noticed that?
Yes, doctor, he has birthmarks, but now he is 1 year old. Already it is from 1 year. I don't have any problem with it.
Right. Yeah, so these birthmarks do not have a problem as such, and these are just skin pigmentation, and you're right. But you know what happens when you see
Wait.
a lot of birthmarks, or sometimes birthmarks which are so.
Can you open your mic, please? Okay.
Hello?
Yeah, continue. Yeah, birthmarks. Yes.
Yeah.
Okay.
Yes. So these, yeah. So whenever we see that there are birthmarks, but sometimes we do see that the birthmarks are more than 6 in number, or they are a bigger in size. So these are the times we need to look into it. So and there are certain conditions which are associated with birthmarks. Have you heard of any such conditions?
No, doctor, no, I don't know anything. I thought it's normal because many children will have. I don't think anything is associated with it.
Yeah. So yes, most kids have the birthmarks and they fade away. But in Oliver's body, we also found some pigmentation in his armpits and in the groin area also.
Okay.
So have you also noticed that?
Yes, doctor, but I thought it's just simple, nothing. So anything related to it?
Yeah, so when we see these features, that there are many birthmarks, and there is some pigmentation or in the armpits, and like in Oliver, we have also seen there is a little bump on his arm. Okay, so we some so it tells us something called as neurofibromatosis. Have you heard about this before?
No, doctor, no. This is a new thing for me. What does it mean, doctor? What?
Yeah. So I can understand this is something which is very unexpected, and but it's quite important for you to know about it. So basically, this condition is known as neurofibromatosis, or NF NF1. Okay, are you with me?
Yes, doctor, I am with you.
Yeah. So basically, as I told you, it's called neurofibromatosis. It means, there is something which is related to the nervous system of the body, and fibromas are basically masses which are present in the skin or in the nerves. Okay, so those are called neurofibromas. I know this is too much information for you, but I really want you to understand this. Okay,
What will happen, doctor? What will happen from this condition?
Yes, Harris. So basically, now that we know that Oliver has it, and my consultant has also seen him, and he thinks it is NF1. So from now onwards, there are certain things we'll be looking into. We'll be having his checkups for his eyes. Okay, then we'll be monitoring his growth and development.
Why do you want to check the eyes? It's just simple birthmarks. Why do you want to check his eyes and do some checkups, doctor?
Yeah. So as I told you that when we see this collection of symptoms like this birthmarks and the armpit pigmentation and those masses, we are thinking of NF1, and in this we also see sometimes changes in the eyes and some kind of masses in the eyes.
3 minutes
okay
left. Okay.
Yeah, so just to be sure, we'll be checking his eyes, and we'll be also checking his back, so that we know how he's developing. Okay, and yeah, so
okay, doctor, I have one doubt. No, I did not see you people doing any blood tests, and you are telling he has some condition. How is it possible? I know that blood tests are needed for this.
Yes. That's a very important question which you have put up, Harris. And basically, you are right. We have not done any blood tests because this is a clinical diagnosis. So there are certain criteria, and clinically we can diagnose. Of course, we will be doing a blood test from now. Like, we'll be doing a blood test to confirm the diagnosis. Okay. But it's mainly a clinical diagnosis. So that is why we just thought of telling you about it, so that you know what's happening with all.
I have a doubt. Does this condition runs in families?
Well, yes, most of the time it does run in families. Yeah, so it does run in families.
Okay, I see some I see some similar birthmarks in his father. Do you think he also has the same condition?
Well, we need to have him evaluated, and it's so good that you have told me about this. So I would really write this in my notes and get him evaluated, if that is okay with him.
Yes, doctor. Now I am very much worried about Oliver. What else can happen, doctor, apart from eyes? Anything, any serious thing can happen with him?
I can imagine this is too much information for you, and you are feeling worried. But let me assure you that there are very, very, very rare chances of having something very serious or life threatening, and most kids live their life fully. And so that's why we'll be monitoring him. Those rarest chances are some tumors. But I think you should not worry much about it now. So, and as and when he grows up, and as I told you, we'll be keeping him under our care, and we'll be involving other colleagues also from the orthopedic department and the eye department, and even the geneticist, and as you mentioned about your husband, so probably a physician will be there. So you are everything which is best for Oliver will be done, Harris.
Okay, doctor.
Yeah. So is there anything else you would like to ask?
No, actually time finished, but conclude your things.
Okay. So Harris, today I have mentioned to you about Oliver, that we think that he clinically he is having a condition known as neurofibromatosis type 1, which is NF type 1. And I have told you why we think so, and the things we'll be doing in the future for him. And I know you may feel overwhelmed, and we are here for you, and I'll be giving you some um, trusted material to, you can read about it. You can even go to the websites which I'll be telling you, and if you have any further questions, you please do let us know.
Okay, Doctor.
Okay, thank you.
Thank you. Okay, it was good, but I want to tell you one thing. In the scenario, it was just only given to you that it was seen by the birthmarks were evaluated by the consultant, okay, and he fixed the criteria because there were more than 2 or more criterias in the child, okay. But why you started asking, you noticed birthmarks, is it not? It will be like history, you know.
No, I did not ask it like a history. I just wanted to give her a reference that this, because birthmarks are actually noticed by the mother. They may not worry about it, but birthmark is something the mothers always know. They are
Yeah,
changing
I
the
agree
baby.
with you. But in the
Yeah,
communication scenario, what I want to
yeah,
tell is try
yeah,
to
I got it.
avoid asking her anything.
So
Like
I did not
even,
ask her actually, Dr. Noor, I just told her that you remember you had mentioned me about it. So that is what I am here to talk about.
yeah.
And
But
then
if
the
this
mother
is not,
reverted that no, I have not mentioned, I have not seen. So which is very, very unlikely, you know. A mother who is, taking care of the child will know the birthmarks.
yeah, I do agree with you.
Yeah.
But if in the scenario it is not given to you that the mother mentioned to you about the birthmarks, don't tell her. If it is given in the scenario, you can tell her. This is what I am telling you. Suppose in the scenario it is mentioned that mother is worried about birthmarks and this is her concerns. At that time, you can tell her that you notice the birthmarks and this is your concerns. Otherwise, don't tell it, because what
Yes,
happens?
so that's but because what I wanted to know is that because incidentally, he just noticed the birthmarks. Okay, so but how to then get into a flow of the
I will
conversation?
tell you how to get into the flow of conversation. So I think, yeah, let me comment about other things, then we will go about it. Your other things went well, like the explanation was well, but you took some time to come to NF1. By the time you told the name neurofibromatosis type 1, it was 3 minutes. I was checking the time here, okay. So instead of spending the time on these birthmarks and all, directly go into the conversation. Okay. After here, what is there in the mind? The background scenario here is in the mother's mind. It is there that he was admitted for some simple condition like for some maybe pneumonia or something. Now he is fine. Okay, for cold and cough, which was serious or something, and now he is fine. So in the mother's condition, what, she will go home, but this is accidentally evaluated, okay, and this needs to be explained to the mother. So you can directly go to the scenario that, do you know any condition called NF1? After complete evaluation of Oliver by our consultant, he came to the conclusion that Oliver has a condition called neurofibromatosis type 1. Have you heard about it? Okay, then if she may say, if she has seen in some of her relatives, she may say yes or she may say no. Then your conversation will go forward. Did you understand what I'm telling? Right?
Yeah.
Bring this NF1 as soon as possible so that your time will be managed. Okay.
Yeah, so basically, why I got it a bit later is because although I had told her the agenda that I'm talking about Oliver, is because I did not want the shock to be more, because what I saw was that when I explained you from the birthmarks and everything, you were not that much shocked.
Okay.
So that was which I had in my mind, because something which is very incidental and which is a lifelong condition, and you just throw it to the patient, sometimes it may be both ways. It may not work for the candidate also. It's like that. That's how I think about it. But what you are saying can also be done. But I just think that in that way, the role player is not made comfortable also. Although we have like already told about the agenda and we are talking about NF1 now, and by the time I told her NF1, I had already explained the criteria to her.
Yeah, and one more, okay. It depends upon everyone's perspective. But what I want to tell you is try to come to your topic as soon as possible so that you will have more time.
So that's why I was talking about all the armpit spots and the masses and all those things.
Okay. This is one thing. Another thing, when she asked you about the, how badly it can affect my child. Okay. So you gave a hopeful answer. Okay, but still, there are some dangers, like they can develop into malignancies and all these things. As you said, we should tell him at the moment Oliver is fine. We will be following up. And these children have variable expressivity. You don't use this word, but I'm just telling you. You can use the word that this condition will present in different ways. You can tell her that few will have very mild symptoms or almost no symptoms at all, and few will have little more and few will have more. But right now we cannot say how it goes with Oliver. We will be just monitoring him every 6 months or 1 year for different things, like we'll be checking his eyes, we'll be checking his blood pressure and see his skin swellings and everything, you can say like this. Because this condition has what we use the word variable expressivity. That means not that everyone will present.
I answered that okay, right? So my answer was okay for you, right?
Yeah. And another thing was about the father. You said rightly that you will refer to an adult physician. You should tell her that at the moment, just by knowing that he has some patches, I cannot confirm that he has the same condition. Maybe or may not be. So we will just do a complete evaluation by the adult doctor to confirm the diagnosis. Okay.
Yes.
Like this. I think it was okay, but you took some time for the this. Okay, for the, but we can do it again. But maybe there is the second candidate. If later after her, if there is time, we will do it again. Okay.
Okay. Thank you.
Thank you. Okay, before going to the next scenario, anyone has any comments?
Dr. Noor, I want to ask whether during the communication we need to go to the management as written in points to consider.
If the mother asks, you will definitely go. Like if the mother asks, how do you manage this condition? How do you treat my child's condition? If she asks, you will explain her like how you will explain to your normal
So
patient.
if we...
Yes, tell me. Like normally as doctors also, when we want to treat our patient, we will explain to the parents, right? We will do this, we will do that, like this. Even to give antibiotics or antipyretics or whatever, before giving to the patient, we need to explain to them. In similar way, if any treatment mother asks, you will explain to the mother, but in her language, using all simple terms, non-medical terms, like this. This was your question?
Yeah, I wanted to know that within this time frame, if we don't get the time to reach to the management during the discussion, will there be a deduction in the mark?
No. All the communication will go according to the mother. Like if there is breaking bad news, mother may get depressed and she may not go to that level, or she may be only worried about treatment only, nothing else. So all depends upon her questions, how she tells you and how you answer her question.
Okay, so only how the
Yeah.
depends on the role player's question only.
Yes. You have to answer her
Thank you.
concerns only. Okay. So we will go to the next scenario. Pediatric, Dr. Rahma, you are here?
Yes, I am.
Okay. So this is your scenario. A pediatric specialist registrar working in busy district general hospital. You're talking to Bob Haggett, father of Demi, a 5-year-old girl with cystic fibrosis. Side room on the pediatric ward. Demi was diagnosed with cystic fibrosis after she had meconium ileus during the early neonatal period. She was treated with anti-staphylococcal antibiotics twice daily for the first 2 years of life and has not had troublesome respiratory symptoms until recently. For the last 3 months, she had been increasingly unwell with tiredness and productive cough. Pseudomonas aeruginosa was isolated for the first time from Demi's sputum samples taken at her last clinic appointment 2 weeks ago. She was admitted 3 days ago and is on IV ceftazidime. She also has chest physiotherapy twice a day supervised by pediatric physiotherapist. Her parents separated 3 months ago and her mother has struggling to persuade Demi to cooperate with physiotherapy at home. There are 3 other children with cystic fibrosis in separate cubicles on the ward. Demi's father has come to visit her for the first time since her admission. He has questioned the nurses about the need for her admission to the hospital and is angry that she has been isolated in a cubicle. Explain to Demi's father the rationale for her current management. Okay. You are not expected to gather the rest of the medical history during the consultation. Points to consider: be sensitive, sympathetic to the father's concerns and feeling. Remain non-judgmental and objective of the father's current situation. Encourage the father to express his views. Recognize the potential for father to misinterpret the situation and criticize Demi's mother. Ascertain the father's pre-existing knowledge of cystic fibrosis. Give clear explanation using jargon-free language appropriated to father's level of understanding. Avoid criticizing either parent. Offer advice and further information on cystic fibrosis. Demonstrate on up-to-date knowledge of management of cystic fibrosis. Understand a pathophysiology and treatment of Pseudomonas aeruginosa in children with cystic fibrosis. Clearly understand the need for isolation in a cubicle. So as I understand, this is an information giving scenario. Okay. Here the girl is 5 years old girl Demi, and she was well controlled with cystic fibrosis until 3 months back. Okay. In the first 2 years, she was on anti-staphylococcal antibiotics. It was like a prophylaxis. Then she was fine for till the age of 5 years. Now, since 3 months, she had this maybe super added infection with Pseudomonas aeruginosa. So she is unwell, tired, productive cough. And 2 weeks ago, her sputum sample was taken and she was admitted 3 days ago, once it was isolated with pseudomonas and started on IV antibiotics, and she's on chest physiotherapy under pediatric physiotherapist. Okay. Now the problem is the father came and he's angry that why the child is kept in cubicle. Okay.
Yeah.
You have to explain to this. Okay. Just take your time and then we will start. Okay.
Okay, just few seconds maybe. Thank you.
Okay. I'll just give 6 minutes for you. Okay, you are well familiar with the names, right? You have any doubt? Clarify
No.
that.
No, that's fine.
Okay.
Yeah.
Okay, Bob and Demi. Okay. Okay, you can start.
Okay. Hello, good afternoon.
Good afternoon.
My name is Dr. Umar. I'm one of the children's doctor in this hospital. Just to confirm that, are you Mr. Haggett, Demi's dad?
Yes, yes, doctor, it's me.
Nice to meet you, Mr. Haggett. I have been told that you would like to talk to one of the doctors. So I've come to talk to you. Let me know, how can I help you today?
Yes, doctor, I don't understand why my child has been separated in a cubicle, and and I also want to know, does my child really needs admission? She was fine from 3 years now.
Sure, Mr. Haggett. First of all, I would like to tell you that Demi we are taking good care of Demi, and she has a condition for which there are reasons why we are doing this. But before I go into detail of that, I would like to know how much you understand about Demi's diagnosis so that I can build my answers accordingly. Is that okay?
Yes, 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 doctor, sure. Actually, my child Demi has a condition called cystic fibrosis, which I am well known about it. And she was very fine from 3 years now. Till now, no problem at all. Now, all of a sudden, I am away from my child and I feel that something wrong is going on. So I am not happy with it. I feel how my child's condition suddenly deteriorated.
Sure. So, Mr. Haggett, first of all, I'm really glad to know that for last 4 to 5 years, Dam has been well. And I'm sorry that suddenly things have not been great. But there are things which could be in the background going on. As the kids with cystic fibrosis, they usually need regular physiotherapy daily. And what we have been told that recently, Dami's been struggling with the physiotherapy. She's 5 years old, and the kids, they sometimes don't really cooperate with these things. That could be a reason for that. But otherwise, do you aware of that? Why these kids are more prone to infections or such episodes?
Yes, doctor, I was explained before. They have some
Okay.
secretions. I know. But I'm not happy to keep Demi in some separate place like this. Is there any other solution for her?
Sure. First of all, Mr. Haggett, I'm very glad to know that I must appreciate you have the correct knowledge of the condition and you already understand it well. So that's very good. The reason why, as you explained, that children with cystic fibrosis have thick secretions. So what this means, actually, it's very difficult for them to clear up these secretions. And if there is any bug which goes in these secretions, like in lungs, inside the body, it's difficult for them to clear that out, and they get easily infected and for long time as compared to other children. Are you getting my point?
Yes, yes, I got your point, doctor. So how will you proceed with Demi now?
Sure. Just completing what you asked me before. So because it's difficult for her to clear up those bugs, so it's for the best of her safety and health, so that she does not catch bugs from other kids, we have made special arrangement, and we are are keeping him in a separate room. And this happens with all kids with this condition. This is not only Demi. So please don't be upset about this. Okay.
Oh, okay, doctor.
Hello?
Okay, fine.
Yeah. So basically we are treating Demi with eye medications like antibiotics, which is going through this small. In this way, the medication go directly into her blood, and the effect is better. And also, she gets in the hospital 2 times a day. A physiotherapist, a specialist person comes and give her chest physiotherapy, so that again it helps in this episode for her to get better soon. Does this sound good to you? Like, do you agree with me that with these things?
Yes, doctor, yes. So I want to ask, how can we prevent her admissions in future now, since this bug, some new bug has come to her? So how can we prevent?
Sure, that's a very excellent question. It shows that how concerned you are for your daughter. It's basically prevention is more of with the regular physiotherapy and making sure that Demi does not really interact with those who have active infections. But other than that, unfortunately, there is not much we can do. New bug antibiotics through this needle. We will put on her some oral antibiotics or maybe something to nebulize with which goes with a mask, so that we can avoid as much as possible any other episode. Okay.
Okay. So if we have difficulties, like in last 3 months, we had some difficulty in giving a chest physiotherapy. Any support we can get for that? Is there anything available like that?
Sure. I think what we need to do, we first need to kind of have a meeting with you, Demi, and Mum, and we take all of them on board and make sure that we understand how important is the physiotherapy, especially Demi. And then we can set out some practical points that how we can ensure she gets physiotherapy daily, maybe some play associated with some play, maybe some rewards, some sticker charts, something which encourages her. And also the physiotherapist and the play specialist here in the ward are very helpful in making this look like, good for Dami, so that she cooperates.
Yes, doctor, anything, the same thing we have to apply in home?
Yes, that's what I mean, that although she's getting the physiotherapy here by the specialist, but if we talk about this, okay, if we talk about this with Demi and Mom and you, then maybe we can agree on something so that Demi because she has to continue this at home as well.
Okay.
So yeah, we can talk about this more. Yeah.
Apart from this, anything else she can have due to this cystic fibrosis as she's growing up?
Oh, that's another excellent question you have asked, Mr. Haggett. And I'm happy to give you more information in the form of leaflets and websites, because there are unfortunately other system gets involved. Like sometimes these children need to have some special medications to help them with digesting the food, some extra vitamins and stuff. And when they grow older, sometimes sadly they can have diabetes as well. But I don't want to make you worry at this point. What I can do, we can either set another meeting to discuss this, or I can give you like all the leaflets and the website so that you can read about this in your time. Is that okay, Mr. Haggett?
Yes, sure. I am worried about my other children. They may catch this dangerous bug from my child. So anything I can do for them, doctor?
So usually this bug is something the children who have their immune system, their defensive system not very strong, they get that. And the other reason to keep them in the cubicle or in the hospital is that she gets clear of that now, so that she does not pass to anyone who has weak defensive system to fight with infections. So far I would say if they are doing well, if they are healthy, you don't need to worry about them. but this is something a worry for parents anyways.
Okay, doctor.
Yeah. So, Mr. Haggett, are you happy with this, that I told you that why we are keeping Demi in the cubicle, and what are the other conditions linked with cystic fibrosis apart from this lung thing? Or is there anything not clear? I'm more than happy to answer again.
No, doctor, it's clear.
Okay, great. So I'll just bring you the leaflets for you. And anytime, if you have any question, please don't hesitate to ask one of our team members. And we really wish a quick recovery for Demi.
Okay. Okay, just few seconds left.
Okay, thank you so much. It's very nice to talk to you today.
Okay, thank you so much. I think your previous knowledge was okay, but I don't know. Did you ask for the attender here or no need or what? It's an information giving scenario, right?
Yeah, I
You
in
missed.
information giving, yeah, because he's not happy with his wife anyway.
But I don't know if it's information giving, you can ask for the attender.
No, what I have got from the seniors feedback, that if you ask a parent that do you need anyone else to be with you at this time or while we are discussing this, this basically warn them, this kind of give them an impression that something is going to go wrong. So it's mostly in the breaking bad news you ask rather than an information giving or any other scenario.
Okay.
So I don't feel the need of this here. Yeah.
Okay. So I don't know. Anyways, attender, it's the choice according to the scenario. Otherwise, I think it was fine. But when I asked you, apart from that, there was the problem here in the scenario, the parents are separated 3 months ago, and her mother has been struggling to persuade Demi to cooperate with physiotherapy at home. Good, you told her that you will treat some play therapy along with the physiotherapy so that the child will cooperate and will get diverted with her mood. But I was also expecting you to tell social support here. Because there's difficulty for the mother to manage her physiotherapy at home, because the reason is there are 3 other children with cystic. No,
that's not.
No, that's not for her. But still, if she had a problem at home, you will refer her to social support, right?
Yeah, social workers can really support them in these chronic conditions. You're right. I could have said that as well.
Social
but
support.
I was actually expecting a very angry dad, but you were a very calm role player. So if the dad is very angry and keep on blaming, no, my wife can't do it, she has done this, it's her fault, etc., then I might would have said that maybe we can have a think on an idea of involving social workers so they can support, and they can kind of being a middle person who can really make sure that Demi is doing good. But
I was expecting here the social support to the mother, okay, because she's alone and she has difficulty with this. And also you can tell him about the support groups, connecting them to the support groups if he's not connected to it, because it's a chronic condition. Here, I think the rest of the conversation went well. Again, the conversation depends upon the role player, okay? He may criticize or he may not criticize. Here, the main feeling for him is why the attack, why she had an attack when she was fine for 3 years. Another thing is she was in cubicle. These are the 2 things. Another criticizing the mother also, but I just did not wanted to bring it here because I don't know, I did not feel like. Another thing is your answers of play therapy and involving the child is very nice. But along with that, if the mother has problems in managing at home, to connect her to the support groups, social support groups, and even sometimes in the chronic conditions, the social worker can visit their home. And sometimes even some nurses, specialist nurses also visit to them to support them, right?
Sure. Yes. Yes. No,
Yeah,
that's
also
a very good point. Yeah.
connecting her to a, and when you told that you can also tell her that the special you will arrange a session or a meeting with the specialist nurse who is specialized in this cystic fibrosis children physiotherapy to
Yeah.
teach the mother like how she can make the things beautiful or playful and pursue physiotherapy with the child. Okay.
Okay.
These
Okay.
things only just beautifies. It was fine. It went well. Only these things I wanted to tell. Social support and these things. Okay.
Yeah. And support groups. I totally forgot. Yeah.
Social support groups, and also involve the specialist nurse to teach the mother,
Yeah.
like how she can manage her in the child.
Yeah.
Sorry.
Maybe I'll just phrase it because she has been doing that for last 5 years, so she must know how to perform physiotherapy. But in these children, sometimes you need different kinds of physiotherapy, maybe as the children grow.
Yeah,
So
yeah, yeah.
that's a very good, excellent point that I could have involved the CF nurse here and say that maybe we can have a meeting with, yeah. So
Yeah.
that's
Yeah,
another
yeah.
good
Even if
feedback.
the
Thank you so
father,
much. Yeah.
as you said, yeah, I forgot this point, but good you raised it. Even if the father would have criticized the mother, you could
Mhm.
calm him in the same way that it's a
Yeah.
5-year-old child and she's very active in playing. It's difficult to bring them in one place and do the physiotherapy. At the same time, mother may also be stressful because of the social problem of separation, right?
Yeah.
So the social workers should help her. Maybe if she's stressed, also they can take care of her for some time, for few hours
Sure.
like this.
Yeah.
Not only this respite care is meant only for the CP children, or they also
No.
for some other chronic illness also.
Yeah, those chronic illnesses which are like really severe, where one parent has to be with them all the time, even these type 1 diabetics.
Hmm.
So if the family is planning to go for any vacations or anything, or if the mother needs a break or kind of a day out, so they can arrange maybe a social worker, maybe for some time a respite care, just so that there is a nurse there who can do the things for them and keep them, look after them.
Okay, so it can be considered in cystic fibrosis children also if
in
needed.
in severe conditions where feeding needs to be done by NG or gastrostomy, where there needs to
Or
be someone. Yeah.
or the attacks like this and needs regular physiotherapy to prevent complications.
So it all depends on the scenario here. I
Oh,
would not
okay.
mention respite care.
Despite going for respite
Yeah.
care, we can at least go for social nurse, social
Sure.
work,
Okay.
specialist nurse, and support groups. Okay.
Sure. Yeah.
Specialist
Okay.
nurse just to review that how she is doing physiotherapy, is there or any lackings in her, and how to make it more playful and attractive to the child, like this.
Okay. Sure. Yeah. Thank you.
If anyone has comments or if we missed anything, please, we can also miss, don't remember things. Just give your comments, please.
Dr. Noor,
Yes.
yeah, I was just thinking like along with the CF nurse, if the school nurse will also be involved, because if this child is 5 years old, he must be in year 1 and must be having a full day school.
Okay, sure. You can tell, but maybe they go for nursery, right? So you
No,
can.
no, they'll go to full day school from 8
At
o'clock
5
to
years?
6:34. Yeah,
Okay.
that's why. By from once they're 4 years old, it is full day school.
Okay, you can also involve the school nurse and teacher, because always any chronic condition they should know.
Yeah.
In communication scenario, you can surely tell all these things to the parents, like your referrals, to whom you will refer if needed, means in the management, or to whom to involve to give best treatment to the child. Okay, because they should also know, the school teacher and school nurse should always be aware of immediate management in any patients who have chronic illness or who can have problems. Okay. So we will go to our next scenario. So Dr. Yasir, you are here.
Yeah. Yes, Dr. Noor. Assalamu alaikum.
Walaikum assalam. So I will read for you the scenario and then we will do it. Okay.
Yes.
So this is neonatal registrar working in a busy district general hospital, side room on central delivery suite. Lisa Teller, a first year midwifery student. So you can just keep her as Lisa. Lisa is a first year midwifery student. Background information. See, they can also give you with nurse, with midwife, student, everything. Okay. So not just medical student. Background information, you have just attended a delivery at which Lisa was present. Baby Joseph was born by normal vaginal delivery at 38 weeks gestation. Antenatally, a diagnosis of hypoplastic left heart was made. His parents were counseled and treatment options were outlined. They visited the tertiary cardiac center and spoke to the cardiac team who would be involved in caring for Joseph. Throughout the pregnancy, the parents were in regular contact with cardiac liaison sister and the obstetric team. His parents made the decision not to pursue any treatment once Joseph was born. They fully understood the decision they had made and asked Joseph to be kept comfortable after birth. They requested that they as a family could spend whatever time they had with the Joseph. Lisa is very distressed and had asked to talk to you. She feels that we are letting Joseph die and that perhaps his parents do not realize he could have surgery to save his life. Please talk to Lisa about her concerns and give her some information about hypoplastic left heart syndrome. This scenario comes under the category of difficult conversation. Okay. Here it's written, difficult conversation. Points to consider: meet the Lisa in private, somewhere where you will not be interrupted. You need to acknowledge this obviously a distressing issue for her to talk about. Start by exploring exactly what knowledge she has about congenital heart disease, in particular hypoplastic left heart syndrome. Go back to basics, assuming no prior knowledge. It is often a good idea to draw a very basic diagram of the heart at this stage, as it makes explaining the diagnosis much easier when you can visualize it. It is how do you explain? It is a spectrum of disorder where the aortic and mitral valve of the left ventricle are too small and underdeveloped to maintain a systemic output. Okay. Use the diagram to help to explain each of these in turn. Around 200 to 400 babies are born with these conditions each year in UK. There are two main surgical operations: Norwood two-stage procedure or heart transplantation. So either Norwood can be done in 2-stage procedure or heart transplantation. Explain that both surgical operations are major operations and carry significant risk of morbidity and mortality. You do not need to go into great detail about the procedures themselves. Even if Joseph had surgical correction, he would not have a normal heart and he would have many years of both surgical and medical intervention ahead of him. Joseph's parents have had full support of the tertiary cardiac unit in making their decision, and we must now respect that decision even if we do not agree with it. Admire the fact that she's thinking of these issues and emphasize how important it is to be the child's advocate and to ensure that the family of these children have had every opportunity to make fully informed decisions. Ensure that you have covered all of the issues she wants to raise and offer to meet again if she has further concerns, and also offer her further information like internet sources about these heart conditions and various options and supports available. Okay. So before that, I want to ask, especially the people who are working in UK. Now this baby is 38 weeks gestation, antenatally diagnosed with hypoplastic left heart syndrome. After detailed conversation and discussion with the tertiary cardiac center and cardiac team, the parents have come to a decision of not to resuscitate the baby, and just they want to stay with the baby, and they don't want any operation or anything. Okay. So she was not happy. So they are doing this still like this for a 38-week-old with this condition. Is this applied still, or there are any changes? Any idea, Dr. Rahma? Or anyone else is there here, Nabila or Rahma? I think she's not there. Okay, no problem. We will check this out. But anyways, we will do the same scenario now. It is 38 weeks. He was born already, okay, by normal vaginal delivery at 38 weeks. And already a decision has been taken not to pursue any treatment once he is born. Okay, they are fully understood in making the decision. They just want to stay with the child till he is alive. So Dr. Yasser, you are clear about the conversation, right? Hello. Okay, you can start.
Good evening, Lisa. How are you? Are you fine?
Yes, doctor.
Yeah, I think you know me. I am Dr. Yasir, one of the senior registrar working here.
Yes,
I am
doctor,
really
I know you.
okay. That's great, and I am very much happy to know about your to talk about an enthusiastic and keen midwifery student. I know we sit here to talk about an issue. Would you like to tell me what you want from me?
Yes, doctor, I am not happy with the baby Joseph. Recently in our unit, the mother gave birth to him and he was a full-term baby, and he has some problem in his heart. But they don't want to give him any support. They are telling that the parents have told that they don't want to give him any support. They just want to leave the baby like this. I am sorry, I'm feeling very bad to tell this. They want to allow the baby to die, doctor. How can we do this? This is making me really feel very bad, and I don't know, I am not able to
Yeah,
concentrate.
Lisa, I highly appreciated your concern, and
Okay.
I highly appreciate your concern, and I am happy that you are very much keen about this patient, and this attitude is very good in the future for you. But I inform you that this patient has one heart disease. We called it SICKLE left heart syndrome. Have you heard about it? And do you know something about it?
No, by the name, actually, I did not read much about this condition, but by the name, I guess it is the problem is on left side of the heart, and maybe it may be small or something, but still, doctor, now we are in advanced stage, and everything can be done to the child.
Okay, Lisa,
Hmm.
I understand, and it's very difficult situation at the moment to talk about you. But first of all, you are looking at the picture. You are looking that this is our heart look like, and here you see normally both the sides are equal, approximately equal, and the left side is more bigger than the right side. But there is a hypoplastic left heart syndrome, means that left side of the heart is not formed completely normally. It is small in size. As you know, the main function of the heart is to pump the blood to whole of the body. As you see, this left side is very small, and it is unable to pump the blood to whole of the body. So that's the reason it's very difficult for Joseph to live long. But I understand that in this advanced technology and with so much advanced surgery, we can correct this abnormality. But there are some options available. Have you heard about any treatment options?
Yes, doctor. I know that there are major cardiac centers and they are doing very difficult surgeries also. I know, and definitely I know that this condition has some surgery to play a role here. But I don't understand why the parents are not agreeing with surgery.
Yeah, I appreciate, Lisa, your concern, but there are different options, just like there is a change of the heart, we called it as heart transplantation, and other we can call it Norwood two-stage procedure. But I just want to clear you one thing. Even after the this complicated surgeries, even the heart of the Joseph will not be able to work adequately, and that increase the morbidity for the Joseph also and for the parents also. And even these two procedures are also very difficult, and there are chances of more and more morbidities, and there are chances of mortality. And as you know, the Joseph heart is not formed normally. So after even we can do operations, we are not successful to give the Joseph a normal heart. Are you with me?
Yes, I am with you, doctor. That means every child who is born like this will be left to die, doctor. This is what you mean?
Yeah, as you know, in UK there are 200 to 400 babies born per year, but there is a very unnatural way that if we can go through the surgeries, so there are more difficulties with the life of the patients. Although with the surgery, as I told you before, we can just improve small amount of quality of their life, but in the long run we cannot get much improvement.
Okay,
So it's
3 minutes
better.
left. Okay.
Okay. So we, as you know, the parents of the Joseph are in with the liaison of cardiac surgery since the beginning of this pathology. They knew, and the cardiac surgery team discussed them clearly for every aspect. And now we have to give weightage to the decision of the parents, and also respect their decision. Are you with me?
Yes, yes, I am with you, doctor. I have one more question now. Now, Joseph can have a brother or a sibling with same condition. It can repeat in family.
There are chances there are percentages that if one child has some heart problem, that in the families there are chances that he can get other siblings get this problem, but they are very, very rare. So as you know, we have antenatal scans, and if we detect them before, even the options of abortions are available and we can go through them. But I will check also from my senior. They will sit with them and discuss this thing with you in clear manner. Are you with me?
Yes, I am with you. But finally, I thought that by discussing with you, I may think that they may give a trial to this baby, because the baby, when it was born, it was looking very beautiful and nice. I thought, how can we allow this baby to die? I'm really feeling bad with this.
I am with you, and I understand, Lisa. This is very difficult to digest in such a mature baby and having a very good look. But you know, due to this heart problem and with future risk of complications regarding these procedures, surgeries, and also by the lung heart problem, the quality of life we cannot improve. So it's better we can follow the respect of the decision of the parents. You don't be worry. I will arrange a meeting with my consultant. I will provide you some websites, and also I encourage you. You can prepare a slide presentation on this hypoplastic left syndrome, and I will help you in this regard. Do you have any more concern?
No, doctor, I don't have any other concern. Okay, did you summarize? Hello? Hello? Dr. Yasser, you are listening to me. Go. Your time was 30 seconds. Please summarize.
You
Hello?
can hear me now?
Yeah, I can hear you. When you stopped and when we disconnected, there were 30 seconds. Just summarize now.
Okay. Miss Lisa, up till now we have discussed so far that this Joseph born with heart problem. We called it hypoplastic left heart syndrome, in which the left heart of the heart is not fully developed. And although with this advanced technology and this so much advanced surgeries, but still we are unable to give a good quality of life to Joseph. So it's better we can give respect to the decision of the parents, and we want to spend more and more time with their child. Hope you can understand very well. Thank you.
Okay, thank you. Okay. It went well. Before that, I want to see what others will answer. Like for my question, that there are other children also with same condition. Will you allow them to die also like this? What will be the answer? Anyone else wants to try for the answer for this? Yes, we have 41 participants. Anyone else?
It's up to the parents also, because you have autonomy for the parents' decision. Also, you have to respect the parents' decision, and the medical the consultants. They do that. There is a one One scenario we did for this, there is a parent's right, and also sometimes the medical, like you
Yeah,
do it.
autonomy, actually. Autonomy
Yeah,
can be
autonomy.
considered, autonomy cannot be considered.
This was not coming in my mouth.
Yeah,
Autonomy.
so here for me, it is my feeling. The answer should be like, will you allow all the babies to die? Again, it depends upon the decision of the parents,
Yeah,
also the cardiac team. You have to tell. Maybe if the parents, some parents, even though we tell that the child will have lots of morbidity and mortality with the operations, they may insist and they may want, they may say that we hope that our child will be fine. We want to go for surgeries. In such a situation, do you think it's a 38-week-old gestation and the parents are insisting to go for surgery and they want a life for their child? In such a situation, don't you think that we will go with their autonomy and do everything for the child?
Yeah, we go in some if the parents they insist, they go.
Yeah,
They
here
go.
what is it's written? Admire the fact that these issues, thinking of these issues and emphasize how important it is to be the child's advocate and to ensure that families of these children have had every opportunity to make fully informed decisions. That means there was many sittings with the cardiac team and the baby was diagnosed antenatally before also, and they were already following up in the tertiary cardiac center, because many times what happens, these babies will be delivered under their supervision in the tertiary cardiac center, right?
Yes.
And
Yes.
if so, the operations may also be ready for them. As soon as the baby is born, they may be ready to do the palliative things before the definitive things. So if the autonomy of the parents is to do resuscitation of the baby and to go for the operation, definitely they will go, because this is a 38 weeks old child. So you have to tell that if we cannot, at this point, I cannot tell that every baby will be allowed to die. Actually, it depends upon the parents. It depends upon the decision made by full discussion with the parents and the cardiac team.
Yes, exactly. Yeah,
Like
this
this.
is autonomy.
Okay? Because they may ask questions like this. And what else I asked? One more question. I don't remember. Okay. So internet sources is fine. What you told about operations was also fine. At the same time, the surgical operations will also cause mortality and morbidity is fine. He will not have normal heart and all those things. I think everything was fine, Dr. Yasser. Only this point I wanted to tell. Again, it depends upon the autonomy of the parents and the joint discussion with the cardiac team. Okay, so here also is very important. Like, I agree with you, but still Joseph's parents have had full support of the tertiary cardiac unit in making their decision. We must now respect the decision, even though if we don't agree with it. Like that, we have to tell this point to her. So Dr. Amina is telling parents which should be considered as surgery can prolong life but would not have full productive life. Yeah. Even though some parents, if they don't want their child to die like this, it's their autonomy. So Saria was raising the hand. Dr. Saria, you have any comments?
Actually, I was thinking if I ask this question, my answer will be from our side as a doctor. We have to give the parent the full information about the baby health and what could be happening in the future. But finally, the decision and the opportunity for the parents. So this is student, right? So I'm explaining to student.
Yeah. You are explaining to midwifery student.
Midwife.
She's not a medical student. Okay.
So just I will tell her, always we have to think what we have from our side. We have to explain everything frankly to the family. What could be happening for the baby, and they have the decision.
Yeah. You're right.
I guess no need to dig in the the details of operation, because the best one who can explain the operation is the cardiac surgeon.
Yeah, you can just at least tell that there are some surgeries to create the means to solve the problem of this condition, but it may not give productive life despite of it. And also he said there in the here it's written heart transplantation also. So anyone has the neonatal guidelines number, will page number, so that we'll just go through only the management part in hypoplastic left heart syndrome of this condition. I'm just opening. If anyone knows the page number, just let me know. So it's page 50.
आजा मेरा बेटा चलो बड़ा गलत हो गया पानी की बोतल दे दो मेरा फोन है पंच में तो दाम में मीटिंग चल रही है देना पापा पानी दे
Mics, please.
अरे बोतल
Allah, please, mics.
तो ये आधी भरी हुई तो क्या होगा मेरा
If I am here and there, I can't. I want to share some slides, and these slides are from osmosis. Okay, osmosis. There are videos on this. You can just watch. But I felt that to remember the pathophysiology and the things, these slides are very good. That's why I just made them into PDF. I'll just share here, and then you can go watch the video. Okay. Because this sickle cell anemia and thalassemia are very important topics for exam. Share. Okay, you can see the screen now. Yes. Hello, you can see the screen?
Yes, you can see it.
Okay. So here, as we know, sickle cell anemia is a genetic disorder, and this problem that the red cells will take the shape of sickle. Because they take the shape of sickle, they are more easily destroyed and there will be anemia. This is the basic thing. Next, what happens? You will have a defective hemoglobin, what we call it as hemoglobin S, HbS. So this is same thing he is showing, the defective hemoglobin. You will have problem mainly in the beta globin. This is defective hemoglobin A, which we call it as hemoglobin S in this. Okay. What happens? Always remember valine. Valine is replaced by, valine replaces glutamic acid here in the beta globins. So mutation in the HBB gene, this produces the defective beta hemoglobin, and it will give the defective shape to it, which makes it sickle. The thing is autosomal recessive. You will have sickle cell disease and sickle cell trait. And the good thing of sickle cell trait is no health problems unless exposed to extreme conditions, like triggers like going into high altitude, or they have dehydration from vomiting, diarrhea or something. What are the 4 things in sickle cell anemia? Always they should have good oxygen, they should have good hydration, warmth, right? So the altitude will cause hypoxia, and dehydration will also trigger the precipitate the problem. So sickle cell trait, usually they will be normal unless they're exposed to extreme conditions. Okay, and decreases the severity of Plasmodium falciparum malaria. Okay, this is for the trait. But what happens in disease? In disease, they may have severe problem with this malaria. Okay. So it is more common here in Africa and the Mediterranean regions. This is what I was telling. What happens? Valine replace normally here the glutamic acid should be there in position 6 of the beta globin chain. This is replaced by valine. This is the reason it happens. Okay, and one more thing you have to know, they are opposite in their character. Glutamic acid is hydrophilic and valine is hydrophobic. This is one of the reason for why it becomes misshapen.
Again, Noor, I did not hear that one. I missed. What was that?
Here, this one, valine is, glutamic acid is hydrophilic. Means it attracts the water. Right?
Water.
Yeah, valine is hydrophobic. They are opposite in their action.
Okay.
Okay.
This is regarding the sickle cell you are talking about?
Yeah, we are talking about sickle cell only. Yes.
Okay.
Then what happens? This is the chains they form. What happens? They will carry this sickle defective hemoglobin. It will carry the oxygen, but once it releases the oxygen, that is when it gets deoxygenated, they get misshapen like this. Okay, and what happens? They will all form chains like this. When they become misshapen, they form chains like this. And these chains, they will finally give the shape of sickle and they become like this after the chains are formed. Okay, and it is irreversible usually and the cell will be destroyed. This is what happens. So what happens? Weakened cell membrane, there is premature destruction, and this will cause anemia, deficiency in RBCs, loss of normal levels of hemoglobin. Whenever there is intravascular hemolysis, there is low haptoglobin, and also hemoglobin will spill out. This spilling out of this excessive hemoglobin which comes out is recircled by the haptoglobin. So you see normally low haptoglobin whenever there is hemolysis. This is not only here, in any case of hemolysis, you will have low haptoglobin. You can remember like this. Okay, and what happens? There will be increased unconjugated bilirubin and you see jaundice. And due to unconjugated bilirubin, you will also have gallstones and also the scleral icterus, that is nothing but jaundice. You can also see some features of extramedullary hematopoiesis in these children because of too much of hemolysis and reduced RBCs. Like what we see same in thalassemia, but not as much pronounced as in thalassemia, like expansion of medullary cavities in the skull, enlarged cheeks, hair on end appearance. And also there is increased production of reticulocytes. You'll have reticulocytosis. That is, and extramedullary hematopoiesis like liver hepatomegaly. Okay, this is how the vaso-occlusion happens. These sickle cells, as I said, many hemoglobins will join together and will form this shape and they get accumulated here in the vessel. Okay, so in bones of hands and feet, they cause dactylitis, other bones pain crisis, and also avascular necrosis of femoral head is also very common in these patients because of again accumulation like this. Okay, and spleen, autosplenectomy, again because of the same reason. Okay, in spleen, what you can see, infarct, autosplenectomy, fibrosis, and in small children, splenic sequestration. Okay, and also they will cause, because of the small spleen, they will have susceptibility to encapsulated bacteria, Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitis. But also you can, is Salmonella is also encapsulated? I don't think so, right? Can someone?
Streptococcus pneumoniae, Haemophilus, and staph.
But they are also more prone to salmonella. You have to
Yeah, these are gram negative. That also are prone to them. Gram negative also prone to them. Neisseria and salmonella, they are gram negative.
Yeah. And salmonella, more common with them is salmonella osteomyelitis.
Yes, more common, and their salmonella is more common to the osteomyelitis for the
Yeah,
sickle
so
cell.
remember extra along with these organisms, salmonella. You can suspect whenever they present with septic arthritis or osteomyelitis. Okay. Why they are more susceptible? Usually these bacteria are opsonized like this and phagocytized in spleen. Since there is autosplenectomy, there are no these big macrophages are not there to opsonize this and destroy this bacteria. This is the reason they are more prone. Okay. Peripheral blood smear, when we were reading in patient info that day, he told that features of hyposplenism. So these you see usually oval jolly bodies like this in the red blood cells. Okay. They are basophilic nuclear remnants. This is one of the feature of hyposplenism. Okay, so what are the complications of this? In renal, there can be renal papillary necrosis. So these patients can present with renal problems also, like hematuria and proteinuria. Then vasculature of penis, they get occluded like this. So when it occluded, priapism, painful and prolonged erection. And we read yesterday, if it is more than 2 hours, naturally what for priapism, what they do, they just try to hydrate the baby, give analgesic, and sometimes swimming in warm water, but still not improved with it and continues for more than 2 hours, you will immediately go to the hospital. This was given there. Then in cerebral vasculature, you can have stroke, again because of the vaso-occlusion, and moya, puff of smoke, collateral vessels like this, you can see. Okay, next is the acute chest syndrome, low in oxygen, hypoxic, what happens? This is a cycle which happens. Usually hypoxic, vasoconstriction, deoxygenated RBCs blocks other RBCs. So you can also have infarction in the lungs and also infection in the lungs. Okay. Then treatment, always remember these points. I always suggest for sickle cell anemia, treatment, vaso-occlusive crisis, always start with oxygen. Oxygen, then hydration. So oxygen, hydration.
Because they are leaking with the oxygen, so they need a first oxygen and fluids.
Yeah, so always start with oxygen. Don't forget, like how we give oxygen in cases of asthma and everything.
Resuscitation. Any resuscitation, we start with oxygen. So they are
also in vaso-occlusive crisis, always start with oxygen, not just for acute chest syndrome. Any vaso-occlusive crisis, priapism, stroke, or anything, always start with oxygen, then fluids, because you have to correct hypoxia, dehydration, and acidosis. And next is warmth. Maybe they are cold, cover them with blankets or some special blankets to make them warm. Then management, I will tell you apart from this, here he has directly gone for opioids. There is 3 ladders here in sickle cell anemia. One is simple analgesia. You can start with paracetamol or ibuprofen. If still not improved, you can go for less strong opioids, what we call it as mild opioids like codeine. And if still not improved, then you can go for strong opioids like morphine. But if the pain is to such an extent that it needs strong opioids like morphine, he should go to the hospital and admission is needed. You got my point? If pain is improved with the paracetamol and simple analgesics, it's okay. He can be managed. Many times hydration and oxygen at home, hydration at home and simple analgesia at home can make them improve. But pain is such an extent that they are in need of strong painkillers like opioids, they need to go to hospital. Then antibiotics, underlying bacterial infection for acute chest syndrome. Yeah, if you suspect bacterial infection, then blood transfusion. Whenever, if they are on, suppose, when we consider blood transfusion in these patients,
If you have acute chest syndrome,
Okay.
one is that, and another one, vaso-occlusive crisis. If they have like also the very low hemoglobin with vaso-occlusive crisis. Two is, one is acute chest syndrome, and another one is you give urgent blood transfusion. I forgot that one.
There is something called top-up blood transfusion or
Stroke.
exchange transfusion. Two things
Stroke
are
also.
here. Yeah, top-up and exchange is here. So exchange blood transfusion we consider for stroke and severe acute chest syndrome. Otherwise, you can give top-up, and also in normal children, they don't have acute chest syndrome and stroke or something, but still their quality of life is reduced due to recurrent vaso-occlusive crisis. Recurrent.
Yeah, when they have
you will consider. Okay.
Frequent admissions, and then you see their hemoglobin is dropped, so you give them top-up to improve their quality of life.
Yeah, if the quality of life is disturbed due to the disease, also you will consider repeated. And if the child is on repeated blood transfusion, you should be aware of the iron overload. Same like in thalassemia, the management. Okay? Only in repeated children. Then penicillin is very important, and polysaccharide vaccines. In vaccines that day we read, if you remember, unconjugated also should be given to these children as extra vaccination. Then hydroxyurea will increase.
Yeah, we remember that you were reading from the guideline.
Hydroxyurea will increase the gamma globulin, in turn HbF, and it will give better quality of life. Hydroxyurea will reduce the means the repeated admissions, reduce the incidence of acute chest syndrome, acute stroke, and all these things. It will give better quality of life with reduced blood transfusions. And treatment, mainly curative, is bone transplant.
It's not fetal hemoglobin, it increases hemoglobin F, I think.
Yeah. It increases the gamma globin. In turn, it will increase fetal hemoglobin.
Yeah.
Okay, so main role is to increase the gamma globin. As I told you, hydroxyurea can also be used in cases of thalassemia also for the same reason, to have more quantity of fetal hemoglobin in the blood, like in thalassemia major. Okay. It is also an indication. It is given in patient info. And next is the treatment. Curative is bone marrow transplantation. And gene therapy, still it is not, you can say it is under trials still, the gene therapy. It's not, means still under research.
Bone marrow transplant is there, gene therapy
Bone
is
marrow
ongoing.
transplant, but you have to tell always a HLA matched donor.
Yeah.
It has to be there and is considered in severe cases only. If you cannot manage this medical.
Allogenic HLA
They should have allogenic bone marrow transplantation. That is, they should have a HLA matched sibling donor. That's all. Finish.
Sorry, I'm still not sure about that.
So any comments before we end the meeting?
Dr. Noor, kindly can you share both files for pathophysiology for thalassemia and sickle cell?
You want these files which I have made PDF?
Yes, and the one we discussed with this thalassemia.
Okay, no problem. I will share for you.
Thank you.
Okay.